How would you feel about AI reading your mammogram? What if that AI was more likely to detect early-stage breast cancer than a human radiologist? What if you had to pay extra for it? What if, over time, it meant that human radiologists got worse at evaluating mammograms? These are the trade-offs that Dr. Robert Wachter weighs in his book, A Giant Leap: How AI is Transforming Healthcare and What That Means for Our Future. Dr. Wachter is the chair of the Department of Medicine at UC San Francisco, and he's been writing about hospitals and the healthcare industry for over 30 years. On this week's Afterwards, Dr. Wachter talks about how AI is used by doctors, nurses, insurance companies, and patients, and he makes a case that AI doesn't need to be perfect, it only needs to be better than the status quo. This is Afterwards from C-SPAN. This week, Dr. Robert Wachter talks about AI's power to transform healthcare. He sat down with general partner at Great Point Ventures, DJ Patil, at the Commonwealth Club in San Francisco in February of 2026.
Thank you for being here, Bob.
It's a great pleasure.
Thank you for coming back to the club. And I guess I get to say the doctor's in.
Sure. A real human doctor.
This is how you know I'm not an AI. I mean it very seriously when I say this is the book that I wish someone handed me before I started working in healthcare. This along with Digital Doctor.
Appreciate it.
And so it's one of the key things that we're going to dive into. But I think to start, I think it's helpful to level set a little bit about healthcare and just some statistics just to help our audience. And then I want to get your reaction to this is, in the US, we spend nearly 20% of our gross domestic product, which is about $5 trillion a year in healthcare. Germany, as you talk about in the book, only devotes about 13% of its GDP. Approximately 1 out of every $3 is spent on administrative paper pushing or other activities that essentially add nothing to a patient's welfare. Those are all direct quotes from you in the book. And then
pretty depressing.
Pretty depressing. Yeah. And then I look at it from my side, from the areas I was responsible for when I was in the administration. We've spent nearly $30 billion of U.S. taxpayer money to move from 11% electronic health record adoption to 96% adoption. And now we have AI. And so I think about it, and I'd love your reaction when you hear these kind of dismal statements, but also potential opportunity of AI. How do you think about the broad scope of these two converging issues of AI and healthcare?
Yeah, well, first of all, thank you for doing this, and it's a great pleasure to be back here. The day before ChatGPT came out, November 29th, 2022, it wasn't like I was sitting there saying, Google's terrible, we need something better than Google. I thought Google was spectacular. It wasn't like before I drove a Waymo, I said, we need a driverless car. Uber's fine and Lyft is fine and driving yourself is fine. But in all those cases, I think the new AI made things better and is in some ways winning the battle. In healthcare, I don't know anybody on November 29th, 2022 who said the system's just perfect and does not need any help at all. So the day I played with GPT for the first time, a little light bulb went off and said, the system is too expensive, too infuriating, there's too much paperwork, there's too much friction, patients are frustrated, doctors and nurses are burned out, and I believe this technology actually provides the opportunity to improve things in ways that we've never seen before. As you said, I wrote a book 10 years earlier about the healthcare's, basically it was about healthcare's move from paper to digital. It was really, the main character was the electronic health record. And it was a book written out of frustration because we implemented these electronic health records, and some things improved. We got rid of doctors' handwriting on prescriptions, for example, but it certainly didn't transform healthcare the way that we had hoped. And in some ways made it worse. And made it worse like you go see your doctor and you notice your doctor's not looking you in the eye, your doctor's sitting there pecking away. You got a patient portal, so you got to see all your information about your labs and doctor's note, but you have absolutely no help in interpreting it. So there were things that the electronic health record did that are useful and digitized our data, but didn't solve all the problems. So to me, the moment and why it's so exciting is that this technology is unlike anything we ever had before and better in some fundamental ways. and the healthcare system is in such desperate need of change. And it's really those two things coming together that create what I called in the title a giant leap. I think the opportunity for real transformation.
One of the things that I think you call out is the beginning of the book, and that we've all heard, was, a decade ago was the chant of like radiologists as a field, radiology as a field is dead.
Yeah.
Like anybody who goes in radiology is going to go down to a dead end.
I think I may have said to my daughter, who was a medical student 7 or 8 years ago, that if you decide you want to do diagnostic radiology, I'm going to withhold your tuition. So it was a little aggressive. But yeah, I think we all wondered and worried and almost took it as a given that here is a field, and I'm talking about the diagnostic part of radiology. There are lots of other things that radiologists do, including sticking catheters in all sorts of places. But looking at a bunch of digital dots on a screen, it seemed inconceivable that wouldn't be replaced by AI, assuming the AI got better. And I wasn't the only one to think that. In 2016, Jeff Hinton, who was the founding father of generative AI, gave a now infamous speech in Toronto. And he said, we should stop training any new radiologists today because it's obvious that in 5 years, we won't need these people. And so that would have been in 2021. And for a year or two, applications to radiology residencies tanked. I don't know whether other parents were as aggressive as I was.
Actually, my cousin was entering the radiology residency program at the time. And I said, "What are you doing?"
What are you doing? Yeah.
And so the same way. So I felt it.
It seemed, and then a couple years later, medical students are very smart, and they looked up and they said, the radiologists seem to be fully employed, and they haven't had their pay cut. And today, and if you'd asked me 15 years ago, which comes first? I take a driverless car, sit in the back seat, and sometimes take a nap. Or our radiologists are all out of business. I would have thought the radiologists are toast. Mm-hmm. And today in this city, in the most tech-obsessed, AI-centered city in the country, there's Waymos everywhere, and we can't hire radiologists fast enough. Mm-hmm. And so I think it's an important and interesting case about the predictions that AI is going to take over the role of physicians are probably overstated. And because if you can't replace radiologists, replacing an internist like me or a surgeon or many other fields, it's hard work. There's something about what physicians do that I think remains quite important, quite special. And I think that's actually quite helpful in terms of the implementation of AI in healthcare, because I think if doctors or nurses thought we were going to lose our jobs, we're pretty good at pushing back, and we wouldn't push back and we wouldn't say, I'm worried about losing our job. We would say, you're going to kill people.
Yeah, I haven't met a radiologist who hasn't said like they're maxed out.
Yeah.
And there's, my understanding is there's plenty of openings of radio, like we're short on radiologists.
We cannot hire them fast enough, and they are desperate for the help that AI can bring to them. And part of that is because you come to the ER of a modern hospital, it used to be the vital signs was we checked your pulse and your heart rate and your blood pressure and your oxygen, and now getting a CAT scan is almost a vital sign. If you have anything going on in your belly or your chest, there's a decent chance you're going to get a CAT scan. If you have cancer, you're going to end up with an MRI, you're probably going to end up with a PET scan. So the volume of images they have to read is just, think about Lucy and Ethel in the Chocolate Factory or the Marx Brothers. It's just, the pace is unbelievable. So even if...
I know what you're talking about.
Yeah, you're old enough to remember. Most people aren't. But even if AI improves efficiency of radiology by 30 or 40 or 50%, which I think is a real possibility, there'd still be a shortage of radiologists. Now, do those curves cross at some point? Probably. I'd still, if my daughter said I want to be a radiologist, I'd still wonder and worry, because I think over a 20 or 30 year time horizon in a world of driverless cars, it's sort of inconceivable to me that over time radiology isn't largely replaced by, or at least diagnostic radiology, by AI. But I think for the foreseeable future, here's the field that's most in danger of replacement, and they are desperate for the help that AI can bring them. And moreover, there are increasing number of studies that show not only is it improving efficiency, but it's actually making it better. The most prominent studies are now in mammography, where there no longer is really any question that if you can get an AI-enabled mammogram, it's more likely to spot an early cancer than a human radiologist.
So let's look at this first through a lens of what that tells us about the future. And in particular, because what I think about is when President Obama asked us to write the first national strategy on AI, and then we kind of looked at it, we thought, oh, the jobs that are going to get displaced first are like the short cook and a bunch of other jobs. And we were totally wrong. And we were wrong because of dexterity, that dexterity is hard. And so I think about that, and I think about the case you just laid out of how we were so wrong on radiologists as technologists. What does that tell you as lessons for us how we should think about the evolution of technology in healthcare?
Well, I think that first of all, in most fields in healthcare, we need the help. That what we're asking human doctors, nurses, nurse practitioners, everybody to do in a world where people are getting older, at least until GLP's getting fatter. Now they're going hopefully in the opposite direction. And the desire for healthcare services is pretty much insatiable. In every other field, we innovate and become more efficient. In healthcare, we innovate, and then everybody wants to have their hip replaced, or their knee replaced, or their cataracts fixed. And so the needs really are insatiable. And I think what we've learned in healthcare is that our go-to solution has been to hire more humans. So creating and sending a bill off to the insurance company has become wildly complicated, and they want all these prior authorizations.
Actually, most of the job reports of the last year have all been up only because of healthcare.
Because of healthcare. We are just this relentless job creator. And at some level, that's fine. It's nice. We sort of guarantee full employment, but somebody pays the bill for that. And if you look at healthcare jobs over the last decade or two, you see the number of physicians going up a little, the number of nurses going up maybe a little bit more, the number of non-clinical staff going up massively. And so I think part of the lesson here is that AI, its first real act, and actually quite importantly economically, is going to be for us to take a good hard look at the 1,000 people that we have in the billing department who are spending a huge amount of time writing prior authorization requests to United Healthcare, sticking them in fax machines. We're the only ones that still use fax machines, waiting a week to get permission to prescribe a drug. I think some of those jobs get replaced. I think the call center gets replaced. I think all of those, there are administrative roles in medicine, and obviously this will be sad, some people will lose their jobs. But I think that the jobs that clinicians do, I don't think get replaced. I think they get remodeled and reorganized. So when we look at, for example, let's take primary care. Primary care, as anybody who's tried to find a primary care doctor in San Francisco knows, is in crisis.
Anywhere in the U.S.?
Anywhere in the U.S. And the reason it's in crisis is for physician specialties, it's paid quite poorly. We talked about radiologists. The average radiologist makes twice what the average primary care doctor makes, and students notice. And so relatively few people go into primary care. A study came out a couple of years ago that said if a primary care doctor spends the entire day just doing the preventive stuff they're supposed to do, that's 27 hours a day. That's if no patient has the nerve to come in sick and with a new complaint. So the job is essentially undoable. So what happens with AI? What I hope and think that AI can take a fair number of the tasks that primary care doctors are doing today off their plates. Getting that organized in a way that's sort of cohesive and coherent and makes sense for patients and doctors is kind of tricky. And I think there are a lot of companies trying to do it, and no one's really cracked the code yet. But I think in the future, you can envision a world where, I have high cholesterol. I don't think I need to see my doctor for a refill, or even probably to have given me my Lipitor in the first place. I think problems like getting your vaccinations, assuming people still get vaccinations, I hope. Getting your blood pressure managed, getting your cholesterol.
You went there, I didn't. We're going to go there.
I'm just implying, I'm not saying. Even managing your diabetes, I think a lot of that is algorithmic. And I can see a world where part of the way primary care physicians are relieved to be able to manage complex chronic diseases that patients have is you take a bunch of the tasks that they currently do that probably don't require their level of training and expertise or their income and give it to either AI by itself or AI-enabled solutions that allow the physicians to be more efficient. I think we're seeing a version of that with mental health as well, and that's one where I think we're seeing the first example of something that's inevitable. And that is the AI is doing something that a lot of patients are finding quite valuable, which is providing mental health support and counseling in your pocket at a very low cost, probably $20 a month that you might be paying to GPT. And they're doing something that people are finding quite valuable. And then there are these absolutely horrific cases where you see the AI essentially, encouraging a teenager to hurt themselves. And that's horrible. It needs to be regulated. There needs to be consequences for the companies. But what I worry about is people saying, look, I told you AI should not be used for mental health. And I think that's the wrong call, because you shouldn't be comparing AI to some mythically perfect system, because that's not the one we have. We have the current system. And try to find a primary care doctor, try to find a mental health professional in San Francisco or most cities. And if you can, try to find one for less than $300 an hour. So
or takes insurance.
Or takes insurance or any of that. So I think that we've got to be careful about holding AI to a standard that we don't hold ourselves to. And we know this is going to happen. And how do we know it? We know it because Waymo has driven more than 100 million miles without a fatality, which is unbelievable. And there's no question now that it's safer than a car with a driver. And yet, and I'm sad about the cat.
I was going to say, we're going to bring up the cat. You can't do this without Kit Kat.
As people here know, 2 months ago, a Waymo ran over a little Kit Kat, this bodega cat in the Mission, and it became a front page story in the New York Times. How many cats are run over by human drivers? How many cats are run over by Uber? I'm sure thousands. But there is a risk that in these early stages of technology, particularly a technology like AI, that's so weird that people have real concerns about both what it will do and also will it take jobs, that these single cases become sort of cause celebs and risk, I think, the possibility of losing some of the goodness that it's doing. So the line I use in the book is Biden's old line, don't compare me to the almighty, compare me to the alternative. And the alternative is a healthcare system that really doesn't work very well. So in part of my enthusiasm for AI is I think that it really does improve the ability of the healthcare system to meet the needs that real people have.
Since you went to the...
Went right to Kit Kat.
You went to Kit Kat. What I was going to say, since you went to the Joe Bidenism, I'm going to use one of his other ones, which is, don't tell me what your priorities, show me your budget, and I'll tell you what your priorities are.
Yeah.
And so if we use that and we look at the priorities of the hospital and what you see as a healthcare system, how does that align with how does the prioritization really align with using this technology in a way that is going to maximize it for the patient? And I say that because you can envision a version where we have seen healthcare, I would say the big data era, we had so much promise, or the big data era. Jeff Hammerbacher and myself, both we were working on this ideas. We were in consumer internet, we both went to healthcare, and yet we have only seen big data used to make people money, to deny people care, to do all these things, despite what it could do. How do we make sure that AI isn't going to be just weaponized and it could be weaponized against a physician, to micromanage a physician, or to deny people care, or those other aspects? How do we make sure that this technology...
Or to bill better, to send off a better, more comprehensive bill so that we get paid more, all that stuff.
How do we make sure the technology works for the population, not against it?
I think it's tricky because the forces that really govern how healthcare systems operate are not the right ones. I mean, that you can imagine a world where the healthcare systems have an incentive to promote health and the best healthcare, and that means trying to keep people out of the hospital and keep people healthy. And yet the way most of us are paid these days is still fee-for-service. We get paid more to do a surgery. We get paid more to take care of someone in the hospital than we do to take care of them in their home. Now, a place like UCSF that I think is massively ethical doesn't do the wrong thing because of that, but it does influence what we're going to invest in. And there's nothing about AI that automatically changes those incentives. I do think that as I look at my own institution, the AI that we are implementing now is improving the care of patients, is improving the experience of doctors and nurses. And the economics really are, if we do this, it costs a lot of money to hire and replace a doctor. So if you bring in, for example, the first use case that we all went with is what are called AI scribes. And you may notice when you go see the doctor these days, there's a decent chance if you see a doctor at UCSF, the doctor may take out his or her phone, put it down, say, is it okay if I use this to record the conversation? And
you're going to get eye contact?
And then the doctor actually is looking you in the eye. And it's like, what's going on here? Is there something wrong with me? It's the first technology we've brought into healthcare, maybe with the exception of video interpreters, where everybody says this is fantastic. This has made my job as a doctor better. It allows me to sort of reclaim a little bit of time. It allows me to reclaim the humanity of the visit and not spend all my time creating a note, largely for the purposes of billing. I think, we are, as I think about my life as a clinician and as a leader in a big health system, we are moving pretty fast on bringing AI into our world because we, I think, believe that it's going to be better for patients, better for clinicians, ultimately save money, and that we can do it, and economically it will be advantageous to us, and advantageous because some of the time that we spend is just so stupid. It's just wasted time sending faxes and typing notes and all that sort of stuff.
Stupid, boring things.
Stupid, boring things that actually add no value for patients. And so I think that we're implementing these things relatively promptly. It's all training wheels where this really is important in healthcare. I think the scribe is useful. Being able to read through a 500-page chart and summarize it is useful. It saves me some time. It gives me better information. Where this really goes and makes a huge difference is something that we're just getting to, which is called clinical decision support, which is it helps me make the diagnosis. It helps suggest the right tests for you. It helps me say, there are 2 drugs I could use for your problem, and one of them costs $5,000 and one of them costs $300, and here's the literature that says the $300 one works just as well. I think that is where we're going. That's going to happen fairly quickly, and I think that is where this begins making a massive difference in the quality of healthcare and the cost of healthcare.
C-SPAN's Afterwards podcast continues in a moment. Now back to Dr. Robert Wachter. He's the author of A Giant Leap, How AI is Transforming Healthcare and What That Means for Our Future.
So when you, as I think about digital doctor, I would sort of say it left me on a path of pessimism for technology. One of the things that I found really interesting reading through this book is the very material shift of pessimist to optimist with this technology set. And so I think there's a lot of people out here who are questioning what this technology, like really where they should be on this dial of optimism and pessimism. And so it would be helpful for you to help paint a little bit of the picture of why you shifted so much.
Yeah, in part because I wrote The Digital Doctor 10 years ago, and it was because I had incredibly high hopes. I mean, you helped bring in $30 billion that got us all to implement these electronic health records. And I saw it as, oh, this is going to be spectacular because I love my iPhone, because technologies that I've used before have made my life easier and more convenient and in some ways better, and this is going to be the same. And then we all implemented these technologies and found that, lo and behold, now we're spending all of our time typing, and we've become essentially slaves to the technology. And it was delivering very little of what I hoped it would deliver in terms of this thing called decision support, meaning we were spending all of this time putting in data and getting really very little help in terms of suggesting diagnoses or suggesting the right treatment out of it. And in the book I likened it to if you had a baby, spent all the time feeding and changing the baby, and the baby never smiled at you. Mm-hmm. And that's sort of what it felt like. And everybody I talked to, at least in healthcare, was unhappy with the state of affairs. And I didn't understand why. The answers they had about why it wasn't working made no sense to me. That's why I wrote that book. When I started writing this book, I think I was tilted slightly toward optimism, in part because I recognized that part of the failure of the electronic health record was that it's good at taking in data and storing it. It's not good at processing it, understanding it, and then delivering something to doctors, nurses, or patients that actually improves health and healthcare. So when I used GPT for the first time, I said, I think this is a tool that will do it. And then I spent 1.5 years interviewing 110 people, going to visit the Mayo Clinic and NYU and Epic and other places. And I landed in a place where partly my optimism was because, as I said, healthcare I think is in such dire straits that we need this. Part of it is these tools are really extraordinarily good. They can do things that prior tools couldn't do. They could read a doctor's note. They could help make a diagnosis. I can, on the wards, pick up my phone and say, this is an 82-year-old patient with, you won't understand any of this if you're not a clinician, but this is an 82-year-old patient with a history of CLL who comes in with a fever, white count of 14,000, shortness of breath, has an infiltrate on his x-ray, and has abnormal LFTs and a transaminase pattern. What do you think is going on?
Well, actually, I could I could actually understand it because if I had my pick my favorite AI, I would just say, explain this to me like I'm an eighth grader.
Right, but a normal human couldn't understand any of that. And if I put that into the prior technology tools that we had, it would just sputter. It would, what are you talking about? AI can understand that, and AI can give an answer that in many ways, when I'm on the wards at UCSF, I'm a generalist. So I see patients, and I can take care of most of their problems, but pretty frequently, the patient has a complex cancer or complex cardiology problem, complex infectious disease problem. And I would kind of hope that I would run into my favorite specialist. We call these curbside consults. And just happen to run into somebody in the cafeteria and say, Emma, can I run this case by you? Now I pull my phone out maybe 10 times in the morning and ask a question of it that I couldn't ask to Google or any prior electronic textbook. And it gives me an answer that is pretty darn good. And as Ethan Mollick, who is a professor at Wharton who writes brilliantly about AI generally, one of his tenets about AI is the AI you're using today is the worst you'll ever see. Mm-hmm. So it's already really good. It already does things that no prior technology could do. It already solves a whole bunch of real-life problems in healthcare, whether it's allowing me to look you in the eye or helping me answer a question on rounds. And that is a pretty early phase of AI where it's only going to get better. So I landed in a pretty optimistic place, and also partly optimistic because I think if I land in a place that this is going to be really good for healthcare, but no doctor or nurse is going to have a job, I would have been less optimistic because I like my job, but also less optimistic because then the politics kick in and we would have pushed back on it. But so I think we ended up kind of in a happy coincidence where I think doctors and nurses will keep their jobs for a while. This tool will enable them to be better at their jobs and happier in their jobs. I think it will enable patients to do some things themselves they couldn't do before. And the technology is only going to get better.
Yeah. I just want to remind everyone, we're going to take your questions. So Kara's walking around and you can hand her your cards from. I know we're going to have a lot here. Also, can I ask the team behind the stage for my timer? But I want to go to...
What if it shows we're already 20 minutes over?
I think everyone is plenty okay.
Okay, good.
Because we haven't even gotten to how you really use you use AI. But before we go there, I want to go to, because you brought up this in the mammogram case and the radiologist, one of the things that's been highlighted is now a fee is tacked on for many mammograms to get the AI consult or the AI overlay on top of the image because it's not paid for.
Yeah.
Who pays for AI, and how does this actually work given the rapid, the double digit percentage increases that we've seen in healthcare costs over the years?
I don't think we've figured that out yet, and I think we need to. I'd say most of the AI that we are using today, for example, at UCSF, we pay for. And we believe that that's a reasonable investment because it will allow us to do a better job taking care of our patients and maybe save some money at in the end. And humans are very expensive. So, for example, if we had 1,000 people in the billing department or 400 people in the quality department, and we can get by with somewhat fewer patients if we can enable them to use AI in their work, that ultimately the economics get sort of balanced. But right now, no payer is paying for AI-enabled mammograms. So patients are being asked to pay $50, $75 out of pocket. A lot of patients seem to be willing to do that. I think at the end of the day, though, if it turns out to be a better way of, and demonstrably better, not just more productive, not just less expensive, but actually improve detection rates and save lives, then I think the healthcare system's going to have to figure out how to pay for it. And hopefully there'll be trade-offs there, which is, all right, you pay for a better mammogram, but you have fewer patients who come in with advanced cancer. Our system's not very good at understanding and thinking through those trade-offs, but that's the sort of thing that has to happen. This may ultimately cause us to rethink the entire payment system. And the analogy there would be, if you buy a car and you're going to have to pay extra for AI-enabled windshield wipers and AI-enabled steering wheel, and at some point it just gets silly. And you're going to want, what is the package price for this thing that has as much AI as we need to deliver the best care at the lowest cost? I think this may drive us toward more what's called value-based care, where a healthcare system is paid a fixed amount with the assumption that they will buy and use the AI that helps them succeed in delivering better care at a lower cost. But for now, I think we're going to be in this sort of funky space where there are going to be some AI tools that we as a health system will buy. There may be other tools that you as a patient will want, but insurance is going to take a while to catch up, so you may have to decide whether you're willing to pay the difference. I think for mammograms, if it were my wife, I would be right now.
So there's several questions around payment in payers, and one of the sort of theme here is payers are clearly not held in high regard these days.
You think?
As also, I should disclose, as a payer, also representing a payer myself, but the part there that I think is there is the weaponization of payers in using technology to deny care. You know, we've seen many times where physicians and patients have been empowered to use AI to push back by saying, okay, here's my letter. It gets denied. You're like, make the letter 10 times longer.
Right.
And, we got this sort of spiral. We've had legislation in California using this. And then as you point out, the amount of time that it takes from a physician to deal with the insurance companies, the payers, is just a burden.
Yeah.
And so could you comment on any thoughts on how that model is going to play out?
Yeah, unfortunately, it doesn't change the fundamental dynamics. And the fundamental dynamics are the payer gets a certain amount of money to pay for care. And like any insurer, it is motivated to spend as little of it as it can because the remainder is profit. And that sort of creates a almost inescapable tension in the system where the patient, and I think to a large extent the physician, are motivated to try to get the patient the best care, and that may cost more money, and the insurance company is motivated to try to deny it. I don't see how we get out of that system, that tension, unless you blow up the entire payment system. What we can get out of, though, is a system where I think you need a certain medicine, and my only path to getting it is to type out a request and stick it in a fax machine and hear back from you in 2 weeks. And then you may say, well, okay, we'll approve it, but you have to get it scanned first. Okay, and it's just massively frictionful, frustrating for the patient, sometimes harmful for the patient as they have this delay, massively frustrating for the physician. I see that could get better and faster. And the way that works would be all of the information about the patient is in the electronic health record. You can imagine a world where the AI connects the payer into the electronic health record. So I'm not having to fax stuff back and forth anymore. I order a certain medicine. The insurance company can look at the patient's record to see whether they meet the criteria for that medicine. If they don't, they might ping me and say, you need to get the patient an ultrasound before we approve that. And that maybe even tees up an ultrasound order that I just click. You can imagine that the spin cycle here could get much better, but you could also imagine when generative AI came out and doctors said, oh my God, it can write the prior auth request for me. And it was like, yeah. And then they send it off, and the insurance company has an AI to reject the prior auth request from the doctor.
Right.
And you have this sort of ludicrous arms race. So that is certainly a possibility, but I think we are seeing examples of AI enabling sort of tighter connectivity between the doctor's office or the hospital and the insurance company that should lower the friction. It should improve at least the efficiency of this process.
Let's go down the path of the physician's actual use, your use of AI. What does the ideal human dyad look like, the human AI dyad look like to you?
Well, it looks sort of like when I'm on the wards now at UCSF, I am using mostly a tool that is available just for physicians. It's a San Francisco company called Open Evidence, which is basically GPT for doctors. And the reason I say it's for doctors, they limit subscribers to doctors, but also it's trained not on the entire internet. So in its database is not Reddit and The Onion. It's really all the medical literature and guidelines and all that. It's really quite good. So I'm using that all the time. As I say, I'm using an AI scribe for a lot of my patient encounters. 1 out of 5 patients has a past medical record longer than Moby Dick. That's 600 pages. So the idea that I'm going to be able to read it and review it in the 3 minutes I have before I see you is ludicrous. It's impossible. So I'm now using a tool that can summarize a patient's past medical record in 30 seconds, and it's pretty good. So those are the kinds of tools I'm using. But I think where this goes over time is right now I will pick up my phone and dictate into Open Evidence what I just dictated to you. That's kind of silly because everything I said to it is in the patient's medical record. It's in the patient's past record. It may be in the scribe note that I just created. So in the future, you're going to have that kind of decision support embedded in the electronic health record. You are then going to have, it's going to suggest the diagnoses that it thinks are compatible with what, the patient's history and what's going on with the patient today. It may even suggest what the best tests are or the best treatments are. So I think it's going to become my wingman. I think it's going to become my companion that's going to help me be smarter, have access to specialty level knowledge in a way that right now I can't get other than calling or running into my favorite specialist. And I think that just makes medicine better and safer. We haven't talked about patient-facing tools, but
we're going to get to patients.
Oh yeah, I think patients will have versions of that as well.
But before we go to patients, how do you make sure that physicians don't become AI stupid?
Yeah.
And what I mean by that is, we've seen the example where some lawyers have used it and it makes up citations. People just kind of gloss over stuff. You kind of develop this laziness that happens around this. How do you avoid that, or how should you think about that?
Yeah, I'm not sure because I think it's a fundamental human flaw. I mean, here's I think the conundrum as I see it today. These AI tools, whether it's a scribe or a chart summarizer or a diagnostic suggester, are good enough to be useful, but not good enough to be fully trusted without looking over their shoulder. So the system that we will create for the foreseeable future will be what's called the human in the loop, and in this case, the doctor in the loop, meaning my job will be the AI may do its thing and suggest something, and it's right 95% of the time, but I'm going to look over its shoulder, I'm going to bless it, and I'm going to be the final person who signs off on the reading of the X-ray or on the diagnosis. Sounds good, but as you, I think, are implying, humans suck at that task. We are really not good at remaining vigilant over time in the face of an AI tool or a technology tool.
As we've seen with self-driving cars.
As we've seen with self-driving cars. If you've ever seen, I don't own a Tesla, but I have seen a Tesla's owner's manual. And there's a little ditty written by, I'm sure, a very expensive attorney with a very good sense of humor, because it says, this thing we call self-driving is actually not self-driving, and the driver should remain vigilant at all times. Like, that's a joke.
Yeah.
And there have been 100 fatalities in Teslas where that driver was supposed to sort of wake up and say, oh my God, I'm about to hit a wall, and had about a quarter of a second to do that. Like, how can that work? It's impossible. So I think there are two real problems, DJ. One is that we're not good at remaining vigilant when we've learned to trust the technology. And so if the system is, I got to stay vigilant in order because the technology might be wrong, that's a flawed system. The second is what's known as de-skilling, which is not only am I not going to remain vigilant, over time I'm not going to be as good at the thing as I used to be when I was doing it myself. There was a study that came out about a year ago where gastroenterologists were doing colonoscopies. It was in Europe. And they were given access to an AI colonoscopy tool, which puts conveniently a little green box around all the lesions inside your colon that look suspicious. And it's really good, and it improves the gastroenterologist's performance. So great. Then they turned it off. The gastroenterologist's performance was markedly worse than it had been before they used the tool. That was in 3 months exposure to...
3 months only.
3 months only. And then you ask, well, with these newbies, the average gastroenterologist had 10 years of experience doing this procedure. So in 3 months, they got worse at their test. So it's a huge question for us in the medical education business, something we're really obsessing about, which is, okay, we need a new curriculum for our students to learn about AI and when to use it and when to trust it and what hallucinations and all this stuff. Great. Are there things we take off their plates because the AI is so smart? And our answer today at UCSF is no. Our answer is that's a doom loop.
So actually somebody asked this, and you brought it up in the book too, is the Krebs cycle.
Yes.
Sorry if I'm triggering anybody.
No, totally. You should have given a trigger warning.
Exactly. I should have. That was my fault.
Yes, it's the only thing that everybody in medicine agrees on, that we don't have to teach the Krebs cycle, which is this convoluted biochemical pathway that we all learned and were tortured with in med school, and none of us ever used it again. So everybody agrees on that. But beyond that, the central question is, do we need to teach as much as we do today on clinical reasoning, on learning the facts of creating a differential diagnosis for a patient with multiple complaints? And our answer today is yes. Maybe the AI at some point gets good enough that we don't need to teach that anymore and it becomes more autonomous. But for the foreseeable future, I think we have to. And there's one more problem I should bring up, the study that Stanford and Harvard did a couple of years ago, you may have heard about, which was it was doctors diagnosing some complex clinical scenarios themselves. 65% accurate. Great. Doctors with the AI, I think they were up to like 68%. So the AI helped a little bit, not that much. Then they asked the question, how about the AI by itself? 90%. Meaning the input of the physicians actually degraded the performance.
Right.
The best performance was achieved by the AI by itself. So we will see situations like that where not only is the human in the loop sort of maybe asleep at the switch, maybe de-skilling, but actually makes the performance.
My wife calls this, you thought you were smarter than Google Maps.
But you're not, right. Exactly. I think your wife is very smart. So yeah, I think, so those are, that was part of the reason writing the book was so much fun, because these are the kinds, I remember when I decided to write it, a publisher asked me to write, I said, I'm worried it's going to be out of date 5 minutes after I write it. And my editor said, if that's true, you've written a bad book. You really need to think, what are the big cosmic questions that happen when a technology like this enters our world? And these are the kinds of questions of the human in the loop, and what happens when the AI gets better than the human, and how do we make all this work, and how do we pay for it, and all that kind of stuff. It's just infinitely interesting.
Mm-hmm. C-SPAN's Afterwards podcast continues in a moment. Now back to Dr. Robert Wachter. He's the author of A Giant Leap, How AI is Transforming Healthcare and What That Means for Our Future.
So I want to, the amount of questions here is it just shows you how much
we'll just get AI to answer.
Exactly. You're going to have the Bob GPT.
The Bob bot.
But maybe to break this, I want to kind of go in a few directions. One is advice for people. Another is advice for entrepreneurs, and then advice for the future. Mm-hmm. And so maybe let's start with advice for people right now in how they should be really using AI. Like, what do you tell patients? Like, should they be, you've got your scribe.
Right.
Should they come in with their scribe and record everything?
And we have dueling scribes. Yeah. I just saw a pitch from a company that wants to do that.
Yeah, like
yes.
your AI agent talks to my AI agent, and we'll where does this, and then what kind of questions do you think that are really helpful for a person, and where do you draw that line? And I particularly pull this because we are living in a low trust environment right now with misinformation, all the other aspects.
Yeah, and people don't trust their physicians the way they did, don't trust healthcare organizations, don't trust experts in general. So that is the backdrop to all of this. I think if you put in you woke up this morning and you're wheezing or you have a headache and you put that into GPT or Gemini or Claude, you get answers that are generally pretty good. And I think it's fine for people to do that. That said, one of the things that I think I underestimated is when I put a prompt into an AI tool, there's a lot of knowledge and experience that goes into what that prompt says. Meaning I might have 50 facts about a patient at my disposal, but that prompt only has 8 of them. And that is that's a highly cognitive act. It's based on 4 years of medical school, 3 years of residency, 2 years of fellowship, and 40 years of practice. Patients have none of that. And so these tools can work really well for me, and whereas for a patient, knowing exactly what to put in is a little bit dicey. Then when the AI does its thing, I can look at an answer and say, oh, those 2 diagnoses, those are really smart, and I hadn't even thought of number 2, that's good. And number three, no, that's stupid, I'm not going to pay attention. Patients also have very little ability to do that. And this is not to denigrate patients. Basically, as I watched my daughter go through med school, she went from being a layperson to an expert. And so I think we underestimate how complex cognitively it is to put in the right stuff into the prompt and interpret the answer. I did the tech reporter for the Washington Post, who I think still has a job, luckily, asked me 2 months ago to look at 12 responses of GPT to health prompts. And some of them were great, and one or two of them were really dangerous, where I couldn't believe that that's what GPT said. And that's the problem, is patients have no great ability to sort among them. And I'd say the other problem with these tools for patients is I think they need to act more doctorish. Meaning a patient goes into it and says, I have a headache. First of all, it needs to know your past history, which you now can do if you want to load it into GPT Health. Or
do you trust it?
Do I trust them with my data? I think they've got a pretty strong corporate interest not to leak it. So mostly, I'm not sure I'd put in anything super sensitive, but I think mostly, if I thought I was going to get enough value out of it. I think in the future, you probably won't have to do that. I think we at UCSF and other places will have tools like that embedded in your electronic health record. So it will be looking at the data you have in MyChart. I think that's probably better. But if you really want to use these tools, I think it's probably net positive. But I guess what I worry about is if you put in, I have a headache, what you would like is the tool then acts like a doctor. What would I would say, well, tell me about the headache. How long have you had it? What part of your head? Do your eyeballs hurt when we shine the bright light on them? Is your neck stiff? I think those are the tools that patients are going to really find useful have not yet been invented, which are much more back and forth, much more iterative, much more reflective of what a physician would do when you have a complaint. I think we'll get there. But today, yeah, I'd put it in. If I had a complaint, I'd put it in. I think it provides you some more information than you would have without it. I think it gives you a better answer than Google would give you. I might use two different tools. I might put it into GPT and then put it into Claude or put it into Gemini. And if they both say the same thing, I feel a little bit better about the answer than if they give wildly disparate answers.
How much better has it gotten for you as you've done these kind of experiments and played with it? How much has it actually improved in the sense of for a patient over the last year?
A ton. I mean, over 2 years, when GPT first came out and you put in a medical question for it, periodically it would truly hallucinate. I mean, one of my colleagues, Sarah Murray, like soon after GPT came out, she said, could you please write a prior authorization? I'd like to get the insurance company to approve the use of a blood thinner, a Pixaban, a very powerful, dangerous blood thinner, because my patient can't sleep, has insomnia. It's a stupid request, like ridiculous request. And GPT wrote this beautiful prior auth request. It's
like, would you like it in a poem?
And would do it. And she looked at it and she said, maybe I missed some recent research that says blood thinners work for insomnia. She went to the medical literature. It was so persuasive. She put the same query in 3 months later, and GPT said, I can't do that. That makes no sense. There's no research that says. So even over the course of a couple of years, these tools have become much better. And that's why if you used it a couple of years ago and said, it hallucinates, it's never going to be ready for prime time in medicine, it really doesn't anymore, or does it very little. I think they're substantially better than they were a couple of years ago, and they're only going to get better.
How about for people who have rare diseases, chronic issues, things where they've been pushed to the outskirts of medicine, long COVID, Lyme disease? There's plenty of areas. One of the questions also came up about people who are on the margins, LGBTQ populations, other areas where they may not be represented in the literature, or people who are asking questions because they're not sure should they trust vaccines or these other things. What's your advice for people in these other areas that aren't the mainstream portion of healthcare, even though vaccines should be part of the mainstream?
Yeah, well, there you said it. So,
yeah. Captain Obvious.
Yeah, I mean, it knows more than any human today. Mm-hmm. It has more access to more literature than anyone. I think as long as you go in with a little bit of skepticism and don't take anything as absolute gospel, and I do think there's some utility to using multiple tools because they come at the world from slightly different angles, and I think if they triangulate, it's like when I go into Yelp and and TripAdvisor, and they both recommend the same restaurant. I feel a little more comfortable that it's probably okay. I think that as you say, there are certain populations that are not well represented, but that's true for physicians too. I mean, we may not have seen as many patients. I mean, the literature that AI is culling is more expansive than anything I have seen as an individual physician in 40 years. And I remember when I visited the Mayo Clinic and the head of AI there said to me, you know, we worry about bias because what if the AI tool was only trained on, you know, on white people here in Minnesota? And I said, well, but your residents, your young doctors were also only trained on white people in Minnesota. So in many ways, the biases that AI has are real, and I think we have to be attentive to them, but they're probably no worse than the biases that humans have. And particularly as you get to rare diseases, one of my colleagues who you know well, Atul Butte, was a world leader in AI, passed away sadly, had a very, very rare cancer, and found AI extremely useful in researching, what here's this gene signature of this cancer. Is there anybody doing anything interesting about this cancer? And he said the answers it gave him were really kind of expansive and helped him think about this in ways that were more than he could get from any individual doctor or any healthcare organization. So and then the question comes up: what about people who live in rural areas and may not have access? If anything, this gives them better access to, they may not have a cardiologist or a gynecologist or you name it anywhere within 100 miles.
The wait might be 6 months.
The wait might be 6 months. I think the ability to scale and disseminate the knowledge of experts and specialists is greater with these tools than if we try to put humans in all of these places, which I think is impossible.
If you want to be inspired and to see someone who is far ahead of their time, and died far too young, look up Atul Butte and B-U-T-T-E and some of his talks out there and be inspired. In our remaining time left, I want to switch gears here. We have actually 14 students from the California College of the Arts. We have a number of other high school students and others here in the audience. And so what advice do you have for them as designers, the future entrepreneurs, people who are builders these days? Forget those VCs. They have Patagonia vests or something. But let's focus on the builders, the people who are actually going to be building. What's your advice to them as they start to think about using these technologies and actually go try to create things that you would call value that are going to help the actual doctors, the clinical team, the nurses, or the patients?
Yeah, I actually don't really know. I think this world is changing so quickly, and I hesitate to go outside my lane. And I actually should make clear my optimism.
This is not outside your lane.
No, but
you advise a lot of companies.
That's true. But my optimism is largely in healthcare. I worry a lot about AI in the rest of our lives.
Oh, I'm talking
in healthcare.
Yeah,
in healthcare design. I guess I would be all in here. I would be enthusiastic about these tools. I mean, there's got to be a little part of everybody that says, I worry if am I going to have a job? I think that's real, and I think we can't sugarcoat that. It's not clear how that plays out. But I think for the foreseeable future, the human that uses these tools is going to be better at their job and more innovative, and it will free up time and I think cognitive bandwidth to think more broadly than the human who doesn't use these tools. So
let's go the other way.
Yeah.
What things should they not do? You listen to pitches, you hear people bring technologies to you with the hope that it'll make some inroads into UCSF. What are things you're like, please don't do that? or like, that's really unhelpful?
Oh, I think the companies that say, I am going to replace doctors or nurses, I think are stepping into hazardous territory. And it's interesting because a year ago, none of them said that. They were smart enough to be careful about that. There are some that are coming out now that are getting kind of chest thumpy about this. Yeah. And I think that's dangerous because I think that for the foreseeable future, that's not going to happen. I do think there are going to be tasks. You may have seen recently that a healthcare company actually out of UCSF was given permission by the state of Utah to refill prescriptions. I think those sort of little small bites of tasks that doctors currently do, but really don't take doctor-level skill and are frustrating to doctors and are frustrating to patients. I think that's real. I think those are the kinds of things that they should do. But I think that they shouldn't get it too far over their skis now. I think coming into this with sort of a minimum of hubris to say we have lots to learn about healthcare. We really want to collaborate with healthcare organizations, with doctors, with nurses, And even if you succeeded in financial technology or, building a restaurant app, you don't know anything about healthcare. And when they hear that, it's like, oh, we've heard that before. But it really is true. Healthcare is its own special animal. The stakes are really high. The regulatory environment is different than any other industry. And, fail fast doesn't work because we can kill people. So it's important to get it right. And there's something about the humanity of medicine that is, I think, quite special in ways that I think are going to be tricky to quantify. Like, is the humanity of medicine important when I'm getting my cholesterol medicine? I don't think so. I think that feels pretty transactional. I'm perfectly happy if a bot can do it. But if I have cancer or I have a new diagnosis of diabetes or kidney failure, I really do want a human talking to me about that. If a decision is being made about whether I need to go to surgery or start on chemotherapy, I want a human doing that. And I think that's an important balance.
Systems don't have judgment. As you point out in the book, one of the things I think that you develop and you hone as a physician is judgment. And the other point that also a number of questions came up about this is the role of empathy.
Yeah.
So could you comment on judgment and empathy?
Yeah, judgment takes time, and it's in medicine. It's really quite complex. I mean, watch The Pit, you'll see. It's hard to get it right, and some of it, tech optimists would say, in medicine we talk about the eyeball test, and the eyeball test is, and I think The Pit does this quite well, and Dr. Robbie, comes in a room and looks at a patient who on the paper looks okay, but says, this is scary, something's going on here. And one of the things we learn over time is you can see two patients who have exactly the same data. And one of the things I have learned that I think I'm decent at, maybe better at, maybe I'm not quite as good as I think I am, but I think you do learn is that patient's sick, I'm really worried, that patient's not so sick. I don't know how that happens, but it happens in thousands of reps, making mistakes, getting it wrong. I think the AI right now is not good at that. Some techno-optimists say, well, anything that you're picking, I remember a conversation with Vinod Khosla a couple of years ago where he said, well, anything, your eyeball test, what are you looking at? The sweat on the brow, the dilation of the pupil, those are all measurable. Maybe.
We just don't know what to measure.
Yeah, we don't know what to measure, and we don't have the data set to pull that together. Empathy is interesting because these tools can fake empathy. They of course have no empathy. They're just machines. But interesting, as I was watching AI progress in medicine, 3 years ago, it passed a medical licensing exam, and then they started feeding it really hard cases from the New England Journal, and it did really well. And I was sitting there saying, oh, this is pretty damn good. But at least we, physicians, we have empathy. And then studies came out showing that in blinded studies, when you gave answers from AI versus a physician, the mock patients judged the empathy from the AI to be better than the empathy that they got from the doctors. Now, it has no empathy, but it's a really good actor. And so I think we will have to see. I think for many situations that are complicated, do require judgment, are incredibly loaded in terms of, what does it mean to hear that you have a diagnosis of diabetes or cancer or kidney failure or you name it. Having something fake empathy, I don't think is going to be good enough for the foreseeable future. Over time, maybe it is good enough, or maybe, you want the real doctor, great, but you have to pay an extra $5,000 a year for that insurance to get you the real doctor. And at a lower price point, you get fake empathy. That may be good enough for many people. I don't know. I'm not quite sure how this will play out.
In the last few minutes here, let's go to the future. You're actually quite optimistic in the book about why people should go into medicine. And so for those students that are out there, for the future, for the medical students, why is this a secure job to go into?
I think for the foreseeable future, and I'll just emphasize that word foreseeable, I don't think 20 years from now is foreseeable, because I don't think 5 years ago, where we where we are today in AI is foreseeable. So it seems unlikely that we can predict, who could have predicted all the things that social media would do to our public discourse or
right.
to being in school or whatever. I think it's almost ridiculous to be projecting 20 years out. But I'd say over a reasonable time horizon, 5 or 10 years, as I've already said, the most vulnerable jobs to replacement in medicine, which really are radiology and pathology, I still think are safe. because I think the unmeetable needs are such that even if the AI makes the physician 50% more productive, which I think it might, there's still a job for the human, and the job gets better. I mean, the human is able to concentrate on higher order, more complex tasks, has less paperwork to do. And the same thing is true in my job. I'm something called a hospitalist. I take care of sick people in the hospital. If I can get rid of the paperwork, if it can be helping to suggest diagnoses to me, I think it makes me a better if it gives me access to subspecialty level knowledge at my fingertips, I think it makes me a better doctor. I actually think it makes me a happier doctor. I think for my colleagues who practice in the outpatient setting, where the paperwork burden is greater, where they're up all night answering emails from patients, having AI be able to draft some of those answers, I think it just makes the job better, more interesting, and actually paradoxically more human. I guess the other reason I'm enthusiastic is if AI takes the jobs of doctors, that means the lawyers are gone years before. It means
the doctor throwing the lawyer under the bus.
It means the accountants are gone. It means the journalists are gone. I think medicine, because of its complexity, because the stakes are high, because of its humanness, if we go, probably everything else is gone, and we've got a bigger problem than should you take a job as a doctor.
You're responsible for 200 residents every year. Mm-hmm. What are you telling them right now?
Same thing I told the students, that you should be all in on this. You should be using these tools and experiment and trying to figure out where they help and where they don't. But you need to be quite sensitized to de-skilling. So if you use the tools as a crutch, if your go-to response now is you hear a patient's history and you immediately feed it into open evidence or GPT, as opposed to pushing yourself to say, here's what I think is going on. And actually, I think our tools should make us do this. I think our tools should sort of make us put our nickel down before it gives the answer. I think humans are fundamentally lazy. And I do think that if we immediately default to and I find this with writing too. Claude is just an amazing writer and editor, but I'm very careful, and was very careful with the book, write the best version of what I could write by myself. And then my wife, who's a spectacular editor, edited it, and it's as good as it would be. And 98% of the time, I was perfectly happy with it. 2% of the time, it's like, oh, I could use a better metaphor, or maybe this paragraph isn't singing. I'll put it into Claude and see what it does, and half the time it made it better. It's that good. But I think what I'm telling my residents and students is put your nickel down first, because it's really easy to de-skill. Think about how we all stink at reading maps, not just you.
Yeah.
I don't remember my wife's cell phone number anymore. If I lost my phone, I might never see her again. And, we will offload complicated cognitive things in our memory. So it's really important for trainees and for institutions that train people to really think about de-skilling as really a fundamental flaw here, and do everything we possibly can to make sure that people keep their skills up.
Well said. In 30 seconds or less, if you had 5 minutes with the president or secretary of health, and you wanted to really help them think clarity, a president or a secretary of health, fine, we'll pander to the audience here.
Yeah.
What would you have him or her do to really make sure we're on the right trajectory of AI?
I think the risk of over-regulating this outweighs the risk of under-regulating this. I think that in the short term, because regulation is a heavy-handed tool and the government's going to lag behind, it's going to be important to give somewhat of a free rein here. But there needs to be a very high-level task force that brings together all the right people to say, how do we regulate this? Because if you try to fit this into the FDA model that was built around a drug that's going to be static forever, or a device that's going to be static forever, that's a square peg and round hole problem. We need a whole new way of thinking about regulating this. It may be the regulation of AI in medicine looks more like the way we regulate doctors. It has to pass a licensing exam and become board certified in order to bless it. I think we need a whole new way of thinking about regulation. The only way that's going to happen is you bring together a lot of smart people and start with a blank piece of paper. Do not start with saying this has to fit into the FDA's model, because that's just not the right way to think about this.
We could have gone easily another hour. I think this might be a new record for questions here. We've come to that time, and our thanks to Dr. Robert Wachter, author of A Giant Leap: How AI is Transforming Healthcare and What It Means for Our Future. Thank you, Dr. Wachter.
Thanks,
All
man.
right, thank you. That was awesome.
Thanks for listening to Afterwards from C-SPAN. You can watch more conversations with authors like this one every Sunday on C-SPAN 2's Book TV. Book TV and all the C-SPAN networks are now available to watch live on YouTube TV. Learn more at tv.youtube.com. And next week on Afterwards, former U.S. Marine Trevor Reed talks about his memoir recounting his 2019 arrest and imprisonment in Russia and his decision to volunteer to fight against Russia in Ukraine after his release.